on there, but this morning I'm going to still define angina pectoris, and then we'll identify management strategies to improve clinical outcomes, and we will assess the role of risk factors, modification to prevent future cardiovascular events in patients with angina pectoris. Because really, what you're concerned about with angina pectoris is the fact that in the next 5 to 10 years, people will end up having myocardial infarction and or congestive heart failure if it's not well taken care of. So we will be looking at this one patient, JK, 60-year-old woman, who reported to report to your clinic with chest discomfort and dyspnea over the last few months, but only during activity. Primary history type 2. So you see that cardiovascular events, they run together. Dyslipidemia, hypertension, anything to dealing with coronary arteries and endothelial dysfunction. These things run together. So type 2 diabetes, A1C that is more than the normal 5.4%, hypertension, hyperlipidemia, current medications that she's on is aspirin 81 milligrams daily, lisinoprostane daily, rosuvastatin 20 daily. So viral, you did your vitals, resting heart rate was 92 beats per minute, blood pressure 135/82. And EKG reveals normal sinus rhythm. Stress test reveals reversible perfusion defects involving the anterior myocardium. I told you the problem with angina pectoris is that it's on the destination and it travels towards myocardial infarction. And we try to discover or talk about what is causing this to happen. So coronary angiography shows 20% occlusion. Yeah, here you go. There's some occluded arteries, particularly coronary arteries. So 20% occlusion is in the left anterior descending artery. There's 3 major arteries in the myocardium that basically envelopes myocardium and sends blood to perfuse most of the tissue in the myocardium. If you block any of those, and all of us in this room, particularly if you eat Western diet, by the time you're in your teenage years, you already have some occlusion. So all of us in this room have some occlusion in our arteries. The key is it to what extent? So angina pectoris, also known as stable angina, sometimes you hear it being referred to also as stable ischemic heart disease. So, cardinal symptoms: substernal chest discomfort that meets both the following criteria: is provoked by exercise or emotional stress, and or relieved by rest or nitroglycerin. You can also see secondary to coronary artery disease. So if there is vessel disease, and I already told you that a lot of cardiovascular disease are actually vessel disease. So hypertension, diabetes, all of these lead to, or rather they don't lead to, but they're part of their cause is the fact that the endothelial dysfunction in the capillaries and blood vessels. So, if you look at the heart, and I've shown you the vessels, like I said, there are 3 major ones, and the normal artery, you can see the normal artery is just like a pipe. I mean, your vessels are just like pipes, they carry fluid. The normal one, very clean, and things can flow. When you have blocked arteries, so then plaque and fat deposition is already started. So atherosclerotic plaque accumulation within coronary arteries is a major thing. 3 of the key major things. Then what happens with that? Damaged blood vessels and restriction in blood flow to myocardium. You don't want none of these. Then you have imbalance of oxygen supply and demand. Very key. Because there needs to be, it's like a fulcrum, there should be, you've seen that fulcrum, like for law, the symbol, you see the balance, and there's on both sides, it's even. So, oxygen demand by the myocardial tissue needs to be confronted, or at least be supplied by equal amount of oxygen accessibility to the myocardial tissues. Whenever you have a decrease and you're not meeting the demand, bam, what happens? What happens to tissues that don't get oxygen? They die. They necrotize. So when they die, then they're not, participating in the physiological processes of action, potential generation, propagation, and also they're not partaking in the coordinated contraction that needs to happen for blood to flow. They're not participating in it. And so you get pain. Pain is a symptom of the fact that tissue are dying. Chest pain also precipitated by physical activity, because of course as we're doing activity, more physical activity, we are consuming more oxygen, not just in our muscle cells, but also in the myocardium, in the brain, everywhere. And so if you're not supplying that demand, the increased demand, then you have issues. All right, the third thing is plaque rupturing can lead to acute coronary syndromes. And that one, if there's a rupture in this thing here, and it flows into the blood within the myocardium, where is that embolus going next? That's right. It's heading to your lungs. But remember, when blood gets into the vena cava, they get emptied into the left, then it's pushed through the lungs to be cleansed, and oxygenated blood comes back into the myocardium to be pushed through the air to the body with oxygen. So, guess what? If that thing comes off, it's going to go with the blood, and bam, when it gets to the lungs, what happens? What happens? Yeah, we know you already have it right here already, but what happens? What do you mean by pulmonary embolism? What exactly is going on?
No oxygen, sucking blood oxygen.
Yeah, I already told you about the sludge. It's already dislodged, so you have that, a huge chunk flowing freely. What will you do? Block. That's right. What is going to cause the pulmonary embolism is the blockage. And blockage, then you disrupt the normal physiological functioning going on in the lungs in terms of blood flow, and most importantly, because you're going to have impact, you're going to be starting to impact the diffusion of oxygen and carbon monoxide at that interface if you block stuff off. None of it is good. So let's look at the epidemiology of this. 1 in 3 adults in the US have cardiovascular disease. I already told you all that we are walking around because of the way and the food and how we eat. So you might want to think twice again before you eat pizza and all those gooey hamburgers. But it's too late, because if you're past 10, actually even the younger kids they're showing it in the arteries of even younger kids in the US or anywhere where Western diet predominates. So 17 million people have coronary disease, 10 million have angina pectoris. The incidence, of course, will increase with age. You should know this. 25% of men and 16% of women between 60 and 79 years old will have this issue. 37% of men and 23% of women above 80 years of age will have it. And this is what they're saying. But like I said, the background information and what's necessary to have this disease already happening by the time you get to 80 years. All right, angina pectoris is the initial manifestation of ischemic heart disease, okay, in approximately 50% of people. Pathophysiology of this, usually in patients with dyslipidemia, excess low or LDL infiltrates the artery and is retained in the intima, which is what the other schematic showed you, and then formation of the plaque. So oxidation and enzymatic modification of that LDL and its interaction with the lining of the blood vessels. You have release of inflammatory macrophages, development of foam cells, and of course, foam cells will then cause formation of the plaque, narrowing of the coronary and endothelial lumen. Okay, so the pipe usually will be like this normal, but you could go to, even all the way to occluding it, which then impedes oxygen supply to the heart, and even not just the supply, but the perfusion and the uptake of oxygen from the heart is impeded. So in terms of pathophysiology, like I said earlier, the main issue is that's your normal nice vessel. It's clean and round and patent, and blood can flow. There's nothing. But as it possibly increases in the position of the plaques, you can go all the way from 20% occlusion to close to 100% occlusion. Some have been known to be 100% occlusion. That's when you hear about cabbage, where they do bypass surgery to bypass that blockage. At this stage, or between these two stages, you may, that's where we all are living at. We may have some plaques, but we may not experience symptoms. So, the angina occurs because of increased myocardial oxygen demand that is not being fed. So, the consequences will be that your heart will react. Just remember to maintain blood pressure. Okay, blood pressure. Two things determine where your blood pressure is right now as you're sitting. What are those two things? Thank you. Oh my God. Oh my. Did I actually know this? Cardiac output and then what? Oh, group hug. Okay. Systemic vascular resistance. You just made my day. I mean, I've never gone into a class, a P2 class, where they tell me this. So I'm very, very confident with this class, and of course, I think my class, I think. All right, so now, the things that will affect blood pressure include volume here. And of course, what is driving this one is your heart rate. The peripheral resistance, of course, like I said, if you have any alteration in the vessel, so occluding any vessel here would impact this, because then, of course, that vessel is not functioning the way it's supposed to. If you have anything that's impeding volume of flow into the myocardium, so the end systolic or end of diastolic blood volume in the myocardium itself is an issue. So in terms of people with congestive heart failure where you have systemic over presence of fluid, that will impact your cardiac output. And your heart rate, that is your contractility issue. So if you have anything that impacts the myocardium and it can't contract the way it's supposed to, then it would definitely impact blood pressure. So let's get back to why our heart is elevated here. So our heart will start to be elevated because several things will start to happen. The fact that our heart is going up is because this guy over here, anytime he goes down, something over here must go up to compensate for the balance. Okay? So if your heart rate is going up, it's because this guy, something is impacting the blood pressure in a way, and it could be because this guy over here, as this is going up, the contractility here, because it's been pumping so much and so hard, it will start to decrease, and that will impact how much blood is flowing, as well as blood pressure, and the response is your heart will attempt to do much more to pump even extra. So your heart rate will go up when you do vital signs. You have increased myocardial contractility, which I already mentioned, which is what the problem is. There's increased preload, and the preload is that volume that we talked about. And there's systolic blood pressure in some patients. So what are the risk factors? We mentioned the biggies are hyperlipidemia, diabetes, hypertension, obesity, smoking, physical inactivity, family history, of course, plays a role. Male relatives that are more than 55, female relatives that are more than 65 that have this problem. Particularly first degree relatives know that you're carrying the gene, which is first degree. First degree relatives, what I mean by that, your mom and your dad. And also personal history of cerebrovascular accident or PAD, peripheral artery disease. All of these are, including hypertension and even diabetes to some extent, they're all vessel disease or, endothelial dysfunction. So how does it present? Usually you hear about localized chest pain, tightness, discomfort. Maybe on the left side, maybe center of the chest. Some female, we talked about it, going to their back. And some may not tell you about anything. All right, it does not vary. This discomfort doesn't vary with position or respiration. Usually, there's some shortness of breath. Of course, people are trying to catch their breath. It's relieved within 1 to 5 minutes of either resting or termination of whatever provoked you, like maybe stress or or if you take your sublingual nitroglycerin. Why would sublingual nitroglycerin stopping the pain? Why? Can someone tell me the mechanism of that? What is nitroglycerin?
Vasodilator.
Very good. And then when you dilate vessels, what happens? Increased flow. So that's exactly what it's doing here. It would tend to dilate vessels, bring more oxygenated blood, and make it available, and therefore decreasing that symptom. This, by the way, the signs and symptoms of pain and such is called the vein sign, which is, I guess, the guy, the doctor first, saw this and described it. The other thing that you potentially see is that people who have clenched fists or hand over the sternum, because the pain would be, I don't know how to describe it, but sort of like knowing it's there, it's diffused, but it's there. So how do we assess patients with chest pain? Okay, of course we have to do a detailed assessment of symptoms that include what is the quality of the pain, where is the location of the pain, what is the severity of the pain, how long has it been going on. Patients typically do not describe angina as fine pain, but like I said, it's like a pressure, tightness, they talk about discomfort. It's not going to be like a sharp pain, It will be dull. Okay, so that's the other word I'm looking for, dull and diffuse and like pressure. Angina pain is rarely described as sharp or stabbing, as I already mentioned. Does not vary with position, so if you turn like this, it's going to change from when you turn whichever way. What provokes it? Exertion, emotional stress. What would agitate it? We said it would be rest, or if you pop sublingual nitroglycerin. So what are some of the diagnostic tests that would be helpful when you're looking at a patient's chart and you're trying to figure out, of course, anything to do with myocardium, you're trying to run and look at the enzymes that come from the heart, in the heart muscle cells. So why would we be looking for muscle and cellular enzymes? Why? What did we say happened to the tissue and cells? What did you say? Okay, so tissue starts to die, and then what happens? Yeah, they're dying because they didn't get, there's blockage and here. But I'm saying, what is the consequence of low oxygen? But what happens to the cells? Okay, so here is the cell. Here's here. When you have necrotized cells, okay, so maybe, All right, folks. I apologize for my drawing, but this is what your cell, typical cell, will look like with mitochondria, the nucleus, and that, right? So then, of course, this is just one unit of millions that makes up the tissue. So then you just told me, okay, so we're not giving them oxygen, we're not giving them what they need, then they drop dead. Then what happens? Okay, yeah, okay, something will try to eat it up, but when he dies, what is he doing? Because he has content inside, right? He will release the content. It will release the content. So now, so the more cells that die, the more the number, when you go to measure these enzymes, the more you're going to have present. So you need to think of things. It's not all, you need to look at what's going on, the sequence of events. So this is not going to happen until the thing dies. And so what are the enzymes we're looking for? Creatinine, kinase, the myocardial fraction B will be a whole lot, troponin with I, troponin T. Troponin T is the gold standard. So those are some of the enzymes, major markers of enzymes present inside the myocardial cells that are released upon the death of the cell. Because when the cell dies, what you don't have no more is the ability to contain what's within it and be alive and maintain its integrity. It dies and release everything. So, and that's what you can measure. And that's a telltale sign of what's going on. EKG can also show you. Resting EKG, usually, your QRS complex, that, of course, you should have something to compare to. normal or unchanged from previous imaging, low risk of lesions, but if there's changes with ST segment or T waves changes, you are intermediate and high risk for for subsequent lesions that would probably lead to myocardial infarction. So some of the other tests they can try to do would be myocardial perfusion imaging with exercise. So they put you on the treadmill, they will hook you up to put catheter in there to go into the myocardial arteries so that they can and capillaries so that they can see the flow. So they can, the physicians, interventional radiologists usually will do this. They will see the flow and they can measure and actually see the image of where the block is. Particularly if they need to do a bypass, they know where to go bypass at. So echocardiography also with exercise, just that is to see what's going on with the different valves and stuff inside of the myocardium, and also to figure out if there are any embolus inside the vessel. Okay, pharmacological stress test could also be done by giving you a shot of epinephrine. And how and why would epinephrine jolt your heart? What does he do, epinephrine? Right, you're increasing your sympathetic tone. So with that, you're going to be getting the vessels, the myocardium to work faster, demand more oxygen, and then you can precipitate the symptoms. So you can show that they cannot tolerate. So you can engineer or reproduce the same signs and symptoms by either getting them to work harder on a treadmill, or you could just inject them with a sympathomimetic like adrenaline or epinephrine. So we said all of this so that you could see where the problem is, what is causing the problem, and therefore how can we approach treating this. So goal-directed medication therapy is what we want to do. Preferred approach for most patients with this, with anything anyways, I think. So second thing, plan coronary revascularization if it's needed, like percutaneous coronary intervention, PCIs or CABG, if they need to do bypass. All of this, getting in there, treating them, dealing with the issue of occlusion, and maintaining the functioning of the coronary arteries and the functioning and the health of myocardium would prevent people from having heart failure and myocardial infarction and also death. So our goal of therapy is, if it is stable angina, we will explain to you why we need to do all this. So one thing, key cardinal things that you want. This is the key. If you don't remember anything from this lecture, you must remember this. If somebody has stable angina, these are the bedrock things that you have to do for them. So as a clinician, there will be malpractice if you're not doing all of these things. So number one, we need to get them an anti-anginal agent to help with the pain and to slow down all of that. So number two, we need to stop, and I wish I could have my picture of that, the coronary vessels to show you and the obstruction. Why do we want antiplatelet agent? That's right. We want to make sure that we can mitigate that. And okay, the ones that have been formed, if you can go in there and scrub them up, fine. But we don't want any extra one forming. So antiplatelet. So you're going to give them statin therapy for what? For what reason? Okay, hyperlipidemia is already in there, right? This is how they plaque. So you want statin therapy. We want to treat any other comorbidities. They may have diabetes, they may have all this other stuff that's contributing, hypertension, all of that. Treat those. you need to modify lifestyle. Like I mentioned earlier, Western diet is a problem, and so the three biggies: salt, sodium, sugar, and what? Fat. These are things that our food is laden with. You just check it out. Any food that you buy out there has these three in abundance. So these are things that you must do. So alleviate or improve symptoms, prevent further coronary remodeling, because usually once the cell dies, this is not only true for the coronary arteries, for any tissue at all that dies. If you have a tissue and it's like that, I assume that it just is round. If cells die over here, this organ will try to remodel itself and try to make up for the death of those, because now suddenly they're not contributing. And so either it would attempt to be bigger over here to compensate or something. That is called remodeling. Just like you will remodel your kitchen or your bathroom, I don't know. Are you following me?
Yes.
In an attempt to compensate, this guy is going to change the shape and size, because some things will have to either come in and it will get bigger or something. Remodel itself to compensate for the problem. This is a no-no for the myocardium. It doesn't, it's not going to bode well, and so you want to make sure that we stop that process. So, we want to reduce the likelihood of premature cardiovascular death, because that's where we're headed. If we don't do anything, the two things that will happen, I already mentioned earlier: acute myocardial infarction, MI, and heart failure. So we want to make sure we reduce that likelihood. We also want to maintain and restore a level of functionality capacity for that person. Okay. Is everyone following me? Understand what the problems are, what we need to do? If you get what I'm saying right now, you don't need to read that much, because you already know what you need to do, and you know what the issues are. So let's start from our anti-anginal therapy. So what do we want? You want to provide symptomatic relief by decreasing myocardial contractility, because once we decrease that contractility, we will decrease oxygen demand. So you want to bring back down the equation of oxygen supply and demand into equilibrium. And you want to increase myocardial perfusion and oxygen supply. So therefore, we want to dilate to bring some more oxygen in there via more flow. So here is a sequence of what our therapy will be. We want a sublingual nitrate or some sort of long-standing nitrate, because the nitrate was supposed to do what for you? The dilate, right? We need beta blocker. Why do we need to block the beta receptors? What were you saying now?
They deal with the heart, so just not to overwork the heart.
Okay, so beta blocker to do. Yeah, because you want to bring, yes, thank you very much. You're following what is going on physiologically with the vein. And if you follow that, you will know there's no tricks. No case that you cannot solve. No patient that you'll not be able to manage. So yeah, you need to do something about the workload of the heart itself by bringing the heart down. You need to block the calcium channel. Why would you want to block the calcium channels? Can somebody say it loud? Say it loud and say it with pride, because I know you know this. This class, you know. Like I said, you're one of those classes that I will come for this lecture, they know a whole bunch. So I'm very, very pleased with this class. Come on with it. What do we need? Why do we want to block the calcium channels? Because if you go back to your action potential, remember calcium runs in at the point of contractility, and particularly in the myocardial tissue, unlike what goes on in the muscle. In the myocardial tissue, the calciums that are in there, they're already inside the myocardium. They don't need the one in the blood. The one that they need is inside the myocardium. And so if you need to block those channels to at least prevent it also, it's helping as well in terms of the contractility and bringing down the requirement for oxygen demand. Okay, you also need a long-lasting, long-acting nitrate. So you not only do you need the PRN nitrate, you must make sure they have a long-acting nitrate, and if need be, ranulaxin is also necessary. A biosimilar agent is available for this product, and it helps in the whole mechanism of what we need to correct in the myocardium. So I want you to be familiar with this trial, the TIPS trial. The objective here was to compare efficacy of bisoprolol and nifedipine in patients with chronic stable angina. The people that included were people with positive tests. So if you had positive angina tests, in terms of positive, negative in the sense that if we did the exercise and treadmill test and you had pain and you have ischemic or angina pectoris, and you are included in this. About 330 patients were in the study. It was 8 weeks, and basically the treatment groups were balanced according to baseline characteristics. Primary outcome is how long did the ischemic situation of pain and symptom last. So the results, total duration of ischemic was reduced by 67% in 48 hours using bisoprolol compared to nifedipine. So you all remember bisoprolol is what kind of beta blocker? I already told you it's a beta blocker. What kind? It's working. Folks, I want to remind you right now that you're in year 2. You need to know the key in everything is what is called nuance. Are you following? Did you hear what I said? No. The word nuance. Nuances. So what is the meaning of nuance? The slight differentiation and in characters of medication, group of medications within the class. This is where they're going to get you. And this is where actually that's the junction at which you practice as a clinician, is knowing those nuances, because that knowledge is what you bring to bear in somebody's situation to help them. Why am I saying this? You need to know within your beta blockers, within any agent group, class of drugs, what makes this one different from that one? What is the difference in terms of actions of this one? What kind of side effects? You need to know those things. It's really very critical. I'm telling you, after brand generic, if you don't know this, trust me, you have difficulty on neighbors. And I think you're going to have difficulty on my exam as well. So you need to know the different calcium channels. Why can I not use verapamil right here? Why am I not mentioning it? And or why? What's the deal with nifedipine? Why can we do nifedipine? What is that MOA of it that does not bode well in this instance? Okay, so anyways, we know that bisoprolol did better than nifedipine. Heart rate at onset of episode was reduced by 13 beats when you use bisoprolol. So the impact is that beta blockers are more effective than calcium channel blockers for reducing the number and duration of ischemic episodes that are transient. So beta blockers, what is their place in therapy? Their first line for maintenance of anginal symptom relief. So of course, as soon as you can decrease the workload of the heart and oxygen demand, everything comes into balance. In other words, the oxygen supply will come into balance with an equilibrium with the amount that's required to be used. Also, beta blockers have been shown in other studies to decrease morbidity and mortality. Of course, you know there are mechanisms of action for beta blockers. Usually, these guys stay at the AV node, at the conduction. When the impulses are coming, they stop them right there. And so, decrease myocardial contractility via the beta 1 receptors into reaction or blockage. Consequently, then we have reduction in heart rate and myocardial oxygen demand, which basically translates into reduction in anginal symptoms. So all beta blockers could be equally efficacious if they have a lot of beta 1 activity. So the beta 1 blockage are preferred. The ones that have selective beta 1 blockers are preferred. Not that beta 2 cannot do, not that beta 1, beta 2 receptors, non-selective cannot do it, but because they would then jump on beta 2 receptors that are a whole lot of consequences by blocking them. And so you don't want a non-selective here, you want a selective beta 1 blockade. And my friends, the goal resting heart rate that you want to shoot for is 55 to 60 beats per minute. Now, all of you in this classroom, as a burgeoning clinical specialist that you are, do you know what your heart rate is? I'm saying, do you know what your heart rate is? Yours. On a regular basis, you need to know, because the variability in that thing shows you some symptoms about some potentially your heart problems. So what is the normal? If they come in here and check all of us, what would be a normal range? Assuming that you don't have people with AFib and such in here. 60 to where? Okay, so, but the best, if you go and check athletes, like the ones competing right now in Beijing, the heart rate, resting heart rate is right over here around very low. A low resting heart rate is actually better for us because it gets the myocardium, and if you're healthy and you're not having any issues myocardial-wise or with the cardiovascular system, a lower rate is better. So, and also the variability of it, so between when you are awake and when you go to sleep at night, that variability, it doesn't have to go to 120 and then shoot down to 50. It needs to maintain perhaps maybe 10 plus or minus 10 or 20 between that of this number. So you should be running around right now while you're awake, maybe 70, 80 or 85, and then it can go down very nicely down at night. This is why I'm asking whether you even knew what your rates are. Okay. So the numbers that you need to always know are your blood pressure, heart rate, what's going on with you as a person, and you can measure your own blood pressure. There's a number of equipment available. So here are your agents. So I have them listed with the mechanism of action. Of course, you know that. What kind of dose are we looking at for benefit? And then, of course, the drawbacks, which is really all of them. Bradycardia is, the problem will be that some people the blockage may bring their heart rate to sub-limit. It may be like go beyond 55, below 55. That also is not good because you all remember that we humans, we live in some space that is called homeostasis. Heck, even the Earth is inside one kind of homeostatic space with the moon, with the sun. So we need to leave within a certain edge, because if you drop below 55 going further down, you set up another problem in the opposite direction. In other words, you're going to then create this problem of angina pain. Why are we going to be having angina pain when we have decrease in heartbeats? Think about it. Why are we going to push people into pain when it goes further down? This is why that's like, you just can't send people, you need to monitor people and see what's going on. Why would you have almost the same problem, actually even worse off, if you depresses the heart rate even further down too much? What is going to be the problem then? Thank you. Because you're going to impede perfusion, because the key is perfusion. In all of this, the key is perfusion of a certain amount of blood into the coronary vessels to go into the tissues and release the oxygen and nutrient to the myocardial tissues. Anything that you do in the up direction, in the down direction that impacts that, you're going to get the same results. Cell death. So, over-treating is not the goal. You need to be careful, and so some of the side effects is bradycardia, which is also going to be sending us in the wrong direction. We know that Indorol or propranolol can cross the blood-brain barrier and can also, confusion and such. We know bronchospasm, particularly in those that are not cardiac selective. In other words, they also stimulate beta-2 receptors. Avoiding people that have if they have AFib with pre-excitation, increases in ventricular response, you may want to avoid. It may give fatigue, insomnia, people may not be able to sleep. It also will mask signs and symptoms of hypoglycemia. Avoid it if the PR interval on the EKG is more than 24.24 minutes or seconds, I'm sorry. Avoid it in secondary or third degree AV block. If there's block already, you don't want to, because if you put these and you remember it's AV, this where we are doing stuff, and it's already been blocked, and you come and put another block, okay, then we're done. You can just order a casket. Avoid it in active airway disease, particularly those that have that are non-selective. Calcium channel, where are they in therapy? We want the non-dihydropyridine. This is where you give verapamil give. We want monotherapy when beta blockers are contraindicated. So dihydropyridine, adjunctive therapy when beta blockers are unsuccessful, or you can add it in some instances. It's preferred agent if the angina type is vasospastic, or what we call Prince metal. Avoid using non-dihydropyridine combination with beta blockers. Significant drug interaction, like I said. Watch out for those, and also go and know what these interactions are. Okay, so your non-dihydropyridine include verapamil, clofazim. Then you have your dihydropyridine. All right, so let's go to our learning. What was that? Learning exercise. I do have you till 12 minutes, I suppose, right? It is 12. In my own 11:50 and 12 is the same thing. I know we're going to see you again this afternoon. That's for a different class, and this is a practice OSCE. I appreciate that you all are here, but I know that some of your friends decided they will not come. So as a course coordinator of that course, by the time you come out at 11:50, as you come out, the reason why I don't want to just pass it around, because I know you all will be trying to help your sisters and your cousins. So all I want to see you do is come over here in my presence and sign your name that you were in class today. And because I'm going to be awarding some class participation here, and I know that a lot of people participated this morning. I heard a lot of people contributing, and so that was good. So let's look at our learning.
Wait, Dr. Osemeni? You
Yes.
said today is a practice possibly?
Yeah,
Oh.
hands-on. So the hands-on this afternoon. Is this P2? Am I in the right class?
But we were confused because we had never done any of the things that it was asking, so it makes sense if today is a practice.
Okay, so it's hands-on, so that you all could take a look at I think iron machine and some of the things that you already done in the class. So now you're going to practice it. Of course, don't even tell me, because I know we last year spent so much time in blood pressure management. And you know how to do that. So don't even come up with, oh my God, we didn't spend time doing none of this stuff. That's why you're going to be doing hands-on today in practicing. But of course, at the end of it, whatever it is that you turn in, you get great in it. Yes, today, this afternoon. Okay. All right, that's what hands-on is. So let's not digress. Let's come back to this, because what I'm saying, what I'm referencing is that I know some people decided they were going to not come to this class, but as it's my practice, I always reward folks. So I want at the end, as you find it out, put your name there, and I'm going to be watching for those that will be trying to cheat by putting their friends, and I know what's going to happen next. They're going to start coming in, because I know people are texting these people to come. Again, that's cheating. It's not fair. All right, so our learning exercise is that patient that we look at. What happened to it? Okay, so here are some of the problems from that one patient. Remember? Let me see if I can get to the patient again. Oh, okay, sorry. This question is independent, so let me ask the question. So, thus far, here is some information about maybe a patient and risk factors: age more than 40, generally males, race, maybe African Americans are more at risk, but Caucasians also. High cholesterol, HDL. Exactly what I said. I just said it.
No,
They were here.
They
When
were
did they get out? When did they, I need to close the door. When, I didn't see them go out.
No, they did.
They've been here.
It's okay.
All right. So,
We won't do things for 100.
all right. So this class. No, I'm very, very sensitive to this. It's cheating. It's not right. And as professionals, we need to, you're going to be the leaders of tomorrow in this profession. So we need to be, integrity is the number one thing. If there's nothing else, if there's no integrity, everything else is not. All right. So this is what we need to. These are some key risk factors that we need to look at when we assess for people's risk factors. Because you could do your coronary disease risk assessment. Have you ever done this assessment before? Using this chart. Here we are looking at the global risk factor for having a heart problem, heart event, meaning either an MI, congestive heart failure in the next 5 to 10 years. So we look at things like age, what is the total cholesterol, what is the HDL cholesterol, because you remember, the higher the HDL cholesterol, which is the good cholesterol, indicates that -1 in your risk factor calculation. What are the blood pressure numbers, or if somebody is on medication? what is your diabetic status, do you smoke, then we add everything up, and based on the numbers, we can predict within 10 years, this is the risk that these people are going to drop dead of, cardiovascular event. Okay, so the things that you're looking for in terms of the risk are these things, and then you tally up. So what I want you to do in the next just 2 minutes is for our patient, 62-year-old that we talked about earlier, for you to tell me what is their CHD risk, calculate all, put all their points together and let me know what numbers, because we want to figure out, this is all what you have to do for all of your patients. You need to be able to figure out what is the risk that this person in the next 5 to 10 years would have a major cardiac event if we do not control their situation. So this is number one of the things that you'll be doing as you're assessing your patient, reading up on their notes, preparing to put together regimen and course of therapy and course of global plan for their health. Okay, 2 minutes. 2 minutes is too much, maybe 1.5 minutes. And at this point, I'm taking questions. If anybody is confused by anything that I said, I know some of the very astute students already know what the numbers are. What is this guy's risk?
What is the systolic blood pressure diastolic?
Okay, so let's see. The systolic blood pressure is there.
Are you talking about this?
I'm talking about 62-year-old. The very first case, I told you that everything is based on that patient.
Okay.
It's based on JK, 62-year-old patient that came. Okay, so we are looking at what? Based on this patient. So for JK, what would you say there? So on the exam, you can bet your last dollar that I'm going to have something like this in there. What's the question? Now you ask me what the question is after I've said it for like 20 times. For all of your patients, you have to assess what the risk of dying of cardiovascular event is within 5 to 10 years. You have to. It's malpractice that you don't. You have to. And then, how do you get that? What do you use to assess? This is it here, your global risk calculator. You need to bring that up. And what are the factors that you're looking at? You're looking at age, you're looking at LDL, you're looking at LDL cholesterol, which is total. LDL cholesterol, I'm sorry, you're looking at HDL cholesterol. You're checking blood pressure, you're looking if they have diabetes, if they smoke, and you're giving them some certain amount of numbers that have been found to correlate with these issues and events. So then you add up all your points. Your age, you add up all these things, age, LDL, or total cholesterol. So LDL or total cholesterol, you add the numbers for HDL, blood pressure, the points, you add up all the points. If they have diabetes, they probably have, BCS, they have 2 points, for example. So you put all that in that space. This is for men, and also on the next slide, I think, is for females. I'll give you both. So, what are the total points? How many?
I got 12%.
Is everybody getting 12? Because let's add age. What do you get for age? What do you get for age? It is age, because you need to look at the one for females. Using the wrong child is just as good as not doing it. Pay attention, folks. You need to ask those questions. And the questions are genetically and gender specific, existing, gender specific, existing, age specific. So the nuances, age nuance, gender nuance. This is where we have a problem. And the problem is this: for gender, what are you going to use for transgender people? This is typical, this is very, regardless of whatever your political,
What does the hospital guidelines do? Don't you look at what your hospital guidelines do?
well, of course, you do, but what would you think? This is not to out anyone, but it's for proper care, because if they were once male, and then doing the hormones of female, does that make them? Of course, these are things that you need to think about in terms of when you are putting together the management plan, and as well your monitoring, because I'm telling you, it may not be the same kind of outcomes.
Well, do you consider the familial risk before even?
Exactly, so all those things, like,
Gender.
yeah, so which one are you, basically a case in point is right, this, which chart are you going to bring out to use right now? So those are the things that I'm talking about. These are some of the issues that's going to be confronting you all as you come into this profession, that this is more and more happening. I mean, I'm not saying that I have the right answer, but I'm going to check in the literature, because I'm pretty sure someone is sitting down and done the research or thinking of doing the research. Okay, what is our numbers right now, total points?
12.
So if there are 12 points, what is the risk of having events within 5 and 10 years? So are they low risk, very low, or moderate?
Looks like they're moderate.
Okay. So let me see. I think the answer, the key is somewhere here. I'm looking at. All right. So. So if you're looking at, this is man. If you're looking at female, 12. It's not very low. Is it low? And you got 10. Okay, so let's put the numbers in. Age was how many points?
Eight.
LDL was how many points?
0.
No.
Oh, we don't have HDL in the case.
We have no HDL.
Alright, so let's assume, we're gonna assume, because they told us they have hyperlipidemia. So hyperlipidemia, yes. So we don't know the number, so I'm gonna say let's go with 2. To the cholesterol, because they have lipid disorder, hyperlipidemia, we will go with high. Let's just go with high. But usually, you have the labs in the exam, so you see the labs. All right. What else do you not have? Okay, so blood pressure we already know. Okay, HDL. Okay, let's give them benefit of that because they're female. let's say it's 75 and it's -1 then for that point. The blood pressure you already know, you know the diabetic status, and from history, they said they didn't smoke or something of that nature. Okay, so add it up. Okay, so what's our number? 12 or higher than that? What's the total points? Who's this guy here before?
He was.
Okay, now I remember seeing him. Okay, yeah, I did. I saw you. But I didn't know that you know, I'm not sure. I noticed that you walked by me. Did you go this way or this way? I'm acting like mom, so I'm like checking everything. All right, so so what's the number that we all came up with? Come on, folks. Don't sleep.
Well, we're still using the same number, or did you change it?
No, I got 14.
Okay, so this is for women, so I put the chart for women because the case is for women.
I got 14.
You got how much? 15?
14.
14. So that's high risk. Okay, so basically what you do is add the total. Is very easy. You sum all this. You check on the table of where the numbers, total numbers fall. Is this relatively very low risk? If it's less than 10, it's low risk. Is it low? Is it moderate? Is it high? Is it very high? So that's all that you're doing here. Okay, so I'm going to move forward because I don't want us to second learning assessment that I wanted to test your assessment here. The resting heart rate for a patient with stable angina should be what?
55 to 60.
So as you're doing your therapy and putting your regimen together and you're monitoring, when you bring them back to clinic, you want to make sure that it's tending towards here. So if it's not tending towards that, you know that your therapy is not efficacious or they're not complying or something that you need to investigate further to make sure. All right, nitrates. So we do have our short-acting nitrates, which is your sublingual nitroglycerin. Usually they're preferred for immediate, if you want immediate chest pain relief. So you should have your patient to have those, so at least they should have a PRN supply of sublingual nitroglycerin, which the direction should be take one every 5 minutes for relief of any anginal pain as you're making your way to the ER. So they should also have a long-acting on board. So they're third-line agents used as therapy when beta blockers and CCBs are contraindicated. So anyone that cannot do either beta blockers or CCBs, then of course your long-acting nitrate is appropriate. It can also be used as adjunctive with beta blockers and or CCB. So here are your nitrates, your of course nitroglycerin, the ointment, the patches, your various sustained release formulations, extended release formulations, and of course we know some of the side effects: headaches, flushing, hypertension, tachycardia, and also nitrate tolerance can develop to this drug. And so I have a sidebar, not sidebar, but a side that I want you to check into. What other drugs in all the different, in the top 300 do patients develop tolerance to? So not for now. I mean, just write this on your side. It's for your study list for you to know, because these are things that, if you group them like that, tolerance is to this, and it's going to be easy for you when you see things to make a sense of it. Now, we need to know that in general, if a drug or anything is acting on a receptor, once it stimulates the receptors, there's usually a downregulation of the receptors. And so, to some extent, there's a tiny bit of tolerance that goes on, because when you downregulate the receptors, there's less responsiveness. Which, of course, when you take the drug away, it will upregulate. This is why you have those, like hypertensive crisis, who just stop taking their meds and things like that. All right. Okay, some of the contraindications and drug interactions I need to worry about are listed for you, and you can also check them on your top 300 drug list. Okay, ranulaxin inhibit the late inward sodium current. Remember the action potential, the flow of electrolytes, who starts it, who comes at the sustained plateau phase, and what's the role of sodium, potassium, calcium in action potential. I know you did this somewhere in Patho and you thought it was a useless lecture, but now come see that this is all relevant. All right, so ranulaxin targets that sodium inward current, decreases ventricular diastolic tension, and relaxes the muscle of the myocardium. And so by doing so, it basically decreases the oxygen demand. It has no effect on blood pressure or heart rate. So where does it occupy in this field of therapy? It's an alternative to beta blockers of calcium channel if people have angina symptoms and bradycardia or hypertension. Okay, so mark where it sits. It's useful because it doesn't have any effect on the myocardium itself in terms of the blood pressure or heart rate. So therefore, people that need something for angina and have things that are already having issues with, they have issues with the myocardium, this is a drug for it, because it will not touch the myocardium and impact the functionality of the myocardium. And so you can get the benefit of it just decreasing the rate of contractility of the myocardium without having effect on heart rate, causing bradycardial hypertension. So you can use it as an adjunctive therapy when beta blockers and successful in relieving symptoms. It can also be used as adjunctive therapy in patients, like I mentioned, for whom beta blockers or CCD are not adequately controlling symptoms or maybe even contraindicated. So here are some of the physiological effects that it has, side effects, and avoided in patients that have liver cirrhosis, because of course, any agent that goes through the 3-4-50 paths, you need to think about them when there's liver problems, including all of the agents that have been mentioned, including this one. All right, so here is our patient again, 62-year-old female. We already looked through and we've already done the risk factor for coronary, for heart problems or eventuality of mortality or morbidity in 5 to 10 years. We already figured that out. So the question then is, what would be the most appropriate therapy for this patient to start? A, B, C, D. What should we start with? That's the first line, right? You need a beta blocker. Aspirin. Listen, therapy. Use in all patients that have anginal pectoris, unless there's contraindication. So 81 milligrams daily. It's been proven to be beneficial by reducing those reduction in serious vascular events like MI and death. Decreases by 37%. Decreases things risk of maybe like stroke 46%. Decreases risk of requiring coronary angioplasty. So, what does aspirin do? What is the mechanism of action of why are we using aspirin here? Besides the fact that it's also, well, I said it. Besides the fact that,
Protective.
what does aspirin do? Why would aspirin be beneficial? So what is the consequence of aspirin use in this setting? When you say blood thinning, what is it doing? Speak to me the technical. I want the okay, coagulation. Okay, so it's something to coagulate. Then what is under the form? The mechanism that form the foams and then also help in the development of plaque will not happen, right? Or at least will decrease. In addition to the fact that it's also an analgesic, so you can also help with the pain as well. So aspirin though, the dosing, so you could do 162 to 325, but at least I believe you can also do in some patients if they're frail, so think in terms of frailty, in terms of elderly and how much you want to give them. Some side effects that you already know from aspirin. Increased risk of bleeding will be the issue that you won't worry about in elderly or people that have issues with GI problems. You also need to figure out if they have some sort of allergy to these drugs or any of the drugs that we mentioned. And of course, in teenagers, you need to worry about Ray's syndrome in terms of the cerebral effect that it can have in younger children. All right, clopidogrel, second line in therapy for antiplatelet activity as well. It can be used as monotherapy in these patients. If aspirin is also contraindicated, may be reasonable to use it in combination with aspirin in some people that are very, very high risk, particularly if they have PCI, which is that balloon tent opening of the coronary arteries procedure. So here's clopidogrel's mechanism of action. You know this already. Maintenance, dose, benefit, some of the side effects. Of course, you need one of those enzymes in the liver compact, the 3,450 system. So anything that's going to impact those enzyme systems, either up or down, will impact any drug that goes through that pass. Okay? Okay, so here is the algorithm for thinking of how you should approach patients like JK, people with stable angina. So patients with stable angina, though, do they need antiplatelet therapy? Yes. Do they have recent stents in there? No. So no contraindication for aspirin, they get aspirin. Contraindication to aspirin, no. If there's yes, then they, if it's there's contraindication, then they get clopidogrel. If there's stent, so we're going to do dual anti-therapy, aspirin plus a P2Y12 receptor antagonist, which is Wu. So, is it drug-eluting stent? Continue for 6 months to 6 to 12 months. If it's bare metal stent, then they continue for more than up to 12 months of. What agent is that? Your P2Y12 receptor antagonist is. Remember, if you go back, the stool of managing, that's what we've gone through. This is what this. So we've done anti-anginal agents, we've done anti-platelet. Now we're going to start in therapy. Okay, lipid management then, statin therapy recommended for all patients unless contraindication exists. So we can do non-statin cholesterol lowering agent, but there's no data for things like ezetimibe or niacin or your bile acid sequestrants. These medications can lower LDL cholesterol but do not reduce cardiovascular morbidity or mortality when you use them as monotherapy. Improve It trial showed that ezetimibe plus simvastatin slightly reduced the risk of non-fatal MI after acute coronary syndrome. And here are some of the results from that data from that study. This combination can be considered in patients who cannot tolerate high intensity therapy. So you can try to use low dose statin with ezetimibe. That would be appropriate if they cannot tolerate high statin therapy. So, who benefits from statin? High intensity if they have clinical the risk. Remember when you calculated for that lady, high risk of events, high intensity therapy. LDL cholesterol more than 190, high intensity therapy. Diabetes in older folks, 40 to 75, LDL more than 70, and they have their risk of myocardial infarction that is greater than 7.5, high intensity therapy. If they have a risk that's less than 7.5 in the next 10 years of having coronary artery disease or mortality, moderate intensity statin. If they don't have diabetes, their age is 40 to 75, 10-year risk is more than 7.5, then moderate intensity statin. And you all know what that moderate intensity statin is. And actually, for the hands-on this afternoon, you need to remember this. I think either Dr. Poon or somebody went over that in the lecture. So high intensity statin therapy, all patients with stable coronary artery disease that are younger than 75 should get it. People that have reduced all-cause, it's been associated with reduced all-cause mortality compared with less intensity therapy. So we need to always be pushing the envelope with statin therapy for this. Moderate intensity statin for patients that are 75 and older. Of course, we are worried about pushing the envelope over with these and the side effects, rhabdo and all the other issues. We don't want none of that. So patients, unless patients cannot also tolerate the therapy, the high intensity. So what constitutes high intensity? LDL reduction that's more than 50%. So here are some of the drugs and your mechanism and your approach. Of course, atorvastatin 40 to 80, the high dose. Atorvastatin or rosuvastatin, medium to high dose. If you need to reduce LDL by 30 to 50%, and here are the combinations of the different meds and the dose. And if it's low intensity that you're looking for, simvastatin 10, pravastatin 10, anything low dose will probably achieve it for you. All right, so now, excuse me 1 second, I just wanted to know how much time I have left. Oh, it's 11:30 already? Okay. I think I'm almost there, so your PCSK9 inhibitors, okay. The proprotein convertase, what is it saying? Subtilism or something, type 9, whatever you know the name is. Let me see. I don't know where my slide is. The inhibitors of these PCSK9 enzyme systems. The injectable monoclonal antibodies that would help you lower LDL cholesterol, and of course, therefore, lowering LDL cholesterol you directly affect or impact our ability for plaque formation, and by so doing, at least prevent future accumulation of plaque and obstruction of the coronary vessels. So, this trial, the Odyssey outcome, the trials, where they looked at this drug, they looked at Repatha and Praluent. Okay, two biosimilar monoclonal antibodies, and they have biosimilars to them. They looked at it and they compare both in this Odyssey trial, where they looked at almost 20,000 people over 12 months. They followed them for about almost 3 years. And so the study showed that Praluent was significantly reducing the incidence of stroke and unstable angina and all-cause mortality. And that Praluent did not reduce any incidence of cardiovascular death. So while it may reduce unstable angina and all-cause mortality, however, in terms of death in general, it didn't do that much. So drawback, high cost remains a significant barrier to accessing it. Conclusion, then further studies are needed to identify patients for whom the drugs are really cost effective. And I haven't seen anything up until now. I think also the pandemic is not letting us see a lot of information from other trials. So here's another woman, 70 years old, who comes to your clinic, chest discomfort. She only notices discomfort when she experiences extreme exertion, such as running for the bus. She has a history of hypertension, stable angina, class 2, New York Heart Association classification of heart failure. So heart failure class 2. Have you done heart failure yet?
No.
Okay, in heart failure, really, basically, I put it all together. In heart failure, now you are compromised the myocardium in terms of its contractility, so it's not able to contract as it used to. And so the left ventricular ejection fraction, that should be more than 34%, in normal people should be more than 50, that could be compromised. And so when it's this low, we know that they have heart failure and the heart is not confidence issue. Current meds include lisinopril 20, metoprolol 200, complaints of fatigue, that's a high dose, Lasix of 20 twice a day, because of course with heart failure you have accumulation of fluid and you want to do something with that with diuretic. So aspirin 81 daily and atorvastatin 20. The blood pressure is within normal limits. Patient is euvolemic, meaning that they don't have accumulation of fluids, and I think in that case we know that furosemide is doing what it's supposed to be done. So which of the following will be appropriate strategy for this patient? A, B, C, D, E.
We know initiate the calcium
Why are you doing that? When you hear heart failure in the same sentence with calcium channel, what should you be thinking? Huh? Why is it contra? It may be a problem.
Little drop in.
It doesn't, that's right. Because what are you doing? Heart failure is already tanking your heart. And then what do you bring over here? Some more stuff to clamp it down. So, what do you do next? So A is off. What is the option here for this patient as relates to the fact that they have angina? What else can we do for them? They're already, so remember the school of therapy that we need? Why would you go for relaxing?
Because when it doesn't work.
Yeah. So it doesn't have, remember when we said relaxing helps, but it doesn't have impact on the myocardium. So this would be the most appropriate thing to try to add for these patients. If they keep having this still discomfort while on maximum therapy of metoprolol, and you need to look to see that all the other meds are there. They have their statin therapy, they have their antiplatelet therapy. So we're doing all that we can do. What else can we add? We give them a relaxant. Okay, so revascularization in patients with this can happen, so that's another option. Either cabbage or TC, I need to run through the rest now. The Heart Association recommends that we do revascularization, which is cabbage, sort of like it's invasive. You go in, they want to put some stents through there and a balloon to expand and basically scrub the lining to open it up. Okay, so cabbage is preferred, which is the really surgical procedure, particularly if multi-vessel, because you all do not understand that some people may not just have one vessel disease. It may be all the vessels that are compromised. So in that case, they really have to go in there and do a bypass. PCI may be considered, which is just trying to put use balloon and or stents to dilate stuff. It may be considered in greater than one single stenosis, and if they're having severe ischemic symptoms. So, invasive procedure when we don't have any other options to do drugs. So, risk reduction then, guess what? The same thing that we're doing on the stool of our therapy, the stool, the 5 cardinal stools. So I'm gonna get people's weight down. We need to get them to stop smoking. We need to do everything about diet and cholesterol. We need to do something about blood sugar and food. We need to do something about blood pressure and anything in food that would pick that up. So lifestyle modification, blood pressure control. If they don't have any antihypertensive, you can initiate this and the goal of therapy. 130/80, American Heart Association. American family physicians say 140/90, but I think if there's a lot of issues with the patient, I think we need to go with American Heart Association. We need to also look at adverse drug events such as an ADR, like hypertension, acute kidney injury, because I want you to remember that someone that has diabetes and have hypertension and have this problem, that it's a vessel disease, part of the coronary, part of the renal capillaries are also, because a vessel somewhere in the heart just doesn't say, oh, I'm the only vessel in the body. So if it's happening there, it's perhaps happening in all of the vessels around the body. So if it happens in the kidney, you need to be aware that this may impact kidney function and electrolyte abnormalities may exist. All right. Choice of antihypertensives, usually the typical, we know the diuretics, the beta blockers is, right? Lifestyle diabetes management, you've already done diabetes. You know, the goal of therapy is to bring them down, bring the A1C down. We want to do things about severe hypoglycemia to make sure that we don't get that. We need to look at other comorbid disease above and beyond diabetes and long-standing diabetes mellitus. We need to make sure that their life expectancy, you can prolong it more than 10. All right. So physical activity, regular exercise, 3 to 5 days a week, 5 to 7 days a week is what they recommended. Gardening is also included in this, and walking is also included. Weight management, we want to reduce the weight, 5 to 10% of baseline. You know, the normal BMI should be 18 to 24. So if you get above that, we want to see what we can do to bring it down. Of course, diet and exercise. Of course, all of those are very difficult to do. So, but of course, but we have to still do it. Healthy diet, reduce intake of saturated fat, less than 7% total calories. So people you need to first of all teach them how to read labels. That's very, you know. So if you're one of those people that are going to be doing patient education, I believe you should bring all of you, buy some grocery supplies that will have these that you can demonstrate and actually teach people. Not just telling them, but let them see and work with them, just like I'm working with you. Like that's how you need to train, because you're an educator of patients. Trans fat, the only way you can decrease trans fat is stop frying food. So frying food should be a no-no. Can trans fat still form in the oven when you put oil and stuff? I think so, because if you take fat to a certain degree, they tend to form some stuff. So just keep oil at a very low level. Reduce cholesterol intake, even though there's a whole bunch of confusion right now about whether cholesterol is actually the cause of heart disease or not. But for now, we should still be saying, reduce your cholesterol. Do you eat eggs? One egg is already, more than 200 milligrams of cholesterol in it. So that's something that I myself am grappling with in terms of what kind of information are we going to give patients. Increase fruits and veggies. Increase fruits and veggies and low fat dairy products. I know fruit and veggies, fruits may be tolerable, but I know, even I have issues with veggies, but I have to eat my veggies. People need to eat their veggies. It's just like medication. Smoking cessation, this is where you come in as a pharmacist. You must provide smoking cessation therapy, and I know you've done smoking cessation here, so you know how we be able to provide that service. Alcohol consumption, moderation, but moderation, I don't know. Okay, moderation. One drink a day, I think that's a bit too much, but. So, key recommendation again, A, B, C, D, E, antiplatelet agents, blood pressure reduction. This is in mnemonics, folks. A, B, C, D, E, that's your mnemonic. Antiplatelet agents, blood pressure reduction, cholesterol and smoking, D for diabetes and diet, E for exercise. So I have another algorithm here. I'm going to just let you look through those. And of course, I will not end this sort of lecture without talking about vaccinations, right? Vaccinations. Usual flu every year is there. Over age, we need to make sure that they have. So the vaccine needs to be, all required vaccination needs to be there. Flu annually. Pneumococcal, if they haven't had it, they need to have it. And of course, COVID vaccine and also the boosting for such to say they're very high risk. All right, questions for me? If there are no questions, people come by them and